So our next presenter is Cheryl Prescott, and she is our first now in a series of people who is earning her and his MPH. Welcome.
Like that? Okay, whoops, I went back. Okay, good afternoon, everybody. My area of focus in this program is in public health nursing, and my project is a health equity assessment of a clinical practice guideline that all nurses who are certified in sexually transmitted infection care in the province have to use. And I happen to develop these guidelines, so it's very good that I'm doing this project because we got a bit of work to do. But I wanted to start with a definition on the difference between a health inequality and a health equity. But I'm going to thank Shannon for giving such a comprehensive definition this morning, so that I don't get the hook. So I'm going to. We just have to just remember that health inequities are socially produced, and they're perpetuated through socially harmful or injurious conditions. So I, as a DST, this is what we call the guideline, a DST, decision support tool. I, as a DST developer, wanted to know, how do the recommendations that we put forward in sexually transmitted infections care in the province, how do they perpetuate inequity in sexual health, or how do they alleviate inequity in sexual health? I had a bit of work to do. I had 2 reviews. I reviewed 50 health equity tools in the Equity Lens for Public Health Tools Inventory, and I did a 2013 literature review with a focus on health equity with specific search terms of STI, clinical practice guidelines in nursing. And I had the privilege of being able to consult with a provincial working group of nurses representing every health authority who practice in sexually transmitted infection care in their communities. So I could spend the whole time talking about how to pick a tool, how to pick a health equity tool. But I'm not going to do that because I'll get the hook. So what I am going to say, though, is that it really requires a lot of thought. I can see why there needs to be underpinning theory to choose these tools, and one tool does not fit all. We'll come back to that if you have questions at the end. So the tool that I did end up picking was called Assessing Equity in Clinical Practice Guidelines, and it was developed by a cardiologist originally to assess for equity in cardiovascular disease guidelines. It's comprised of 5 questions. I'm not going to go through each question right now because I'm going to go through them one by one as we work through the equity assessment. And I'll tell you why the question is important, how the question could be reflected in guidelines, and whether or not the STI assessment DST adequately reflected it. Another thing I had to do before I started was I had to define disadvantage in relation to STI in the province. And I will say that the nurses on the provincial working group had a problem with the language of disadvantage, and I tend to agree. Sometimes it can imply incapacity. So throughout this presentation, and actually in my paper, I use the language of most affected. So when we look at 2012 annual surveillance reports for British Columbia, for the 4 infections that we routinely, or 4 screening tests we routinely offer in the STI assessment DST, are 4 infections: chlamydia, gonorrhea, syphilis, and HIV. So I looked at those numbers. And when you think about most affected populations in our province, the most affected populations are men who have sex with men, youth between the ages of 15 and 24, young women, and for some infections, our Aboriginal populations. So the first question asks us if we if the recommendations in the guideline address a priority problem for an affected community. And this is important because whatever we highlight in provincial guidelines implies resource allocation. So if we're leaving this out of guidelines, then we are doing a big disservice for those most affected. So you can do this by making sure that your guidelines integrate information on the burden of infection in the province and the social conditions that shape that vulnerability. When I looked at the STI assessment DST, our recommendations are predominantly universal in nature. They're not targeted to any one specific affected population, and they're very granular, right at the lower screening. The questions are around screening and risk assessment, so it's individual and behaviorally based. So, good. Are different intervention effects anticipated in disadvantaged populations over privileged populations? This was important to consider, and we need to put some flags in the guidelines so that practitioners are considering this, because if we overestimate how effective our interventions are going to be, we waste resources. And then if we underestimate how effective our interventions are going to be, we're going to lose out on opportunities to facilitate better health outcomes. So how do you reflect this in a guideline? Well, when I referred back to the health equity tool, the recommendation was you find out what the relevant social determinants of health are that most affect these populations. And in the 2013 literature review, it was pretty clear. Segregation, discrimination, stigma, and lack of access to culturally appropriate services. So we need to include those determinants in the assessment guideline, and also if there's provincially available resources for nurses and communities who are mitigating those social determinants in trying to provide sexual health services. When I looked at the STI assessment DST, you can see there's a theme. It's very individual. The recommendations are at the individual level. We're not necessarily addressing those larger social structural things that affect care for sexually transmitted infection. And we are focused on screening. So the next question is, this was a very important question. I can't see that. Oh, there it is. Okay. I couldn't see where the timer was, but I got it now. This is an important question, and it speaks to exactly what, I don't see her here, Astrid was talking about this morning, about engaging your affected populations, right? How are the effects of the interventions valued differently by your affected populations than they are by your privileged populations? So we need to know this. We need to understand how our public recommendations are valued. If we don't do that, then we really run the risk of disrupting the harm versus benefit of the intervention. And what we may think as public health care providers coming into a community and providing an intervention as a good thing could actually be quite harmful. So we need to be able to do that. The only way we can really do it is through community advisory committees and through connecting into those affected communities. Now, I didn't have time to do this. I didn't have the resources or time to do this in this report. So that's a gap, and I admit it, and it's got to be the next step. But I did consult with RNs in the province and looked through the literature, and the RNs echoed the literature. If you want to know how people value your interventions, ask them. So we really need to start moving into community and moving more towards that community level intervention and community evaluation. So I know that we haven't integrated clients because I've been developing the DST since certified practice came into being in 2010. So it has to be the next step. We have started with RN consultations across the board. Oh my gosh, 2 minutes. Okay, specific attention to barriers. If we're talking to communities, then we're also going to be able to identify common barriers, and those need to be integrated into the guidelines as well. And in the DST, the only kind of barrier we address are those for screening alternatives. and plans for assessing the impact of the recommendations. Do they include affected populations? We have to start doing this to start contextualizing our surveillance data, or we're going to have the same people getting sick and we're not going to get reach into those communities. And so community advisory committees, community-based evaluation of our recommendation, these all need to start happening. So I had 4 recommendations for myself. 1, integrate more population health information into the decision support tool, including burden of infection, including barriers to care. Include provincially supported resources. InSpot is a provincially, it's an online platform for anonymous partner notification that youth really like to use. Put it in the DST so everyone knows they can access it. Recommend assessment of local STI surveillance. That is part of the Canadian Canadian Community Health Nurses competency, is to know what your local epidemiology is to inform your programming. And this is the biggest one and most important one. It's going to be my big hill to climb, but I'm going to get over it. Establish a community advisory network at BCCDC, and then start to look at community-level interventions and community-based research and evaluation. So I had a few challenges in this. One is I had no example to draw from. Couldn't find a health equity assessment of clinical practice guidelines, and I even emailed the guy that wrote the tool. And my time's up, but I'm just gonna say a couple more things. So that was a challenge, no examples, and whoopsie. And I didn't talk to clients, which would have been perfect if I could have done that. But I had this, some great nurses to work with throughout the province. And I think there's great potential to actualize some of these recommendations. So, and I want to thank all those people. Thanks, guys.
Very good. Any questions?
You got questions?
Hi, my name's Alex. I'm in the BA program. I want to thank you for discussing the intricacy behind selecting an assessment tool. This summer, I'm going to be working with Equity Lens for Public Health and the Centre for Aboriginal Health Research using an Indigenous equity framework, evaluating relational environments in the health regions. And I had a question to you. Let's see. Do you think it's problematic to have so many different models of health equity assessment? Can these models be integrated, or should they be integrated? And could they or should they be tailored to specific populations, regions, and projects?
Yeah. So what you're speaking to is a big thing that's come out right now in the health equity literature review, is that we really do need some good theory for to underpin the tool utility, right? So I looked through 50 tools, and I finally found a document that was published by the National Collaborating Centre for Social Determinants of Health, Tools and Approaches for, do you know that document? Use it. Because there actually isn't, the health equity tools inventory is great, but it's 50 tools that you have to go through. And that document actually really clarifies what kind of approach you want to use, what kind of a tool might be applicable. Is it an existing program you're wanting to measure health equity against, or is it a program that you're developing? Does the tool get used retrospectively or prospectively? So I would really recommend you do that. And I can't answer that question because, well, I can answer it, actually. I do think. I can. I shouldn't cut myself off like that. Because I do think, yeah, individual tools are very important for your specific focus and purpose. The danger is if we start to blanket everything with one tool. We're all going to use this for health equity. It's not. We're going to end up in the same place in 5 years. So that's my answer. Okay, thanks. Thank you.